We are going to start our session, which is on bariatric, and I would like to call our respected chairpersons, Dr. V.K. Bhartia, Dr. Tamanas Chaudhury, Dr. Aloy Mukherjee, Dr. Mahendra Narwaria. I would like to hand over the session over to the chairpersons. Thank you.
Hello, good morning. I think not wasting time, we should start the session. Dr. Siddhartha Bhattacharaya, he is a very promising young bariatric surgeon, qualified from James Hospital, Coimbatore, the Mecca of laparoscopic surgery, and is presently working in Columbia Asia Hospital in Salt Lake. Dr. Siddhartha Bhattacharya will talk on the pre-operative evaluation of bariatric patient, what not to miss. Dr. Sai.
Thank you for the kind introduction. Good morning to all, and good morning to the esteemed chairpersons. So I'll be talking on pre-operative evaluation of a bariatric patient. So I have no disclosures. So when we talk about pre-operative evaluation, these are the various aspects that we consider for evaluation. We will look at them one by one. So implications of pre-operative evaluation is in patient selection, assessment of risk of patients. It allows us to optimize the patients adequately. Sometimes based on the evaluation, we also choose the procedure, and we also try to predict the outcome with respect to weight loss as well as comorbidities resolution. So let's look at every evaluation one by one. So the first being the weight-related evaluation, where we look at weight, BMI, calculate the excess body weight, waist circumference. We do body composition evaluation, looking for lean tissue mass versus fat mass. So all this information allows us in patient selection. It allows us to set goals for the procedure and discuss the goals with the patient. And based on this, we also make choice of procedure, as most centers tend to do a stronger procedure like a bypass for a higher BMI patient as compared to a lower BMI patient. And for very high BMI patients, we can even plan for a staged procedure. Talking about BMI, based on BMI, we do the patient selection. These are the new Aussie guidelines which have been published in 2020. Now these guidelines are 5 BMI points lower than the National Institute of Health guidelines and 2.5 BMI points lower than the Asia Pacific guidelines. This is because of the YY paradox, as in the Asian population or in the Indian population, for the same BMI, there is more fat mass percentage. So the BMI points have been lowered. Another interesting inclusion in this guidelines is the inclusion of waist circumference in type 2 diabetic patients, wherein if the waist circumference of females is more than 80 and of males more than 90, is now considered an indication for bariatrics. When we talk about the guidelines, we also have to talk about age. Most international guidelines recommend bariatric surgery between the age groups of 18 to 65. And beyond this, also it can be done under special circumstances in elderly and adolescents. Important point about adolescents is that it should be offered to them only after all obesity treatment measures have been exhausted and they have started developing severe comorbidities. Another important point to remember that they should have achieved puberty before we offer bariatric surgery, ideally, because puberty is a time of multiple changes like skeletal changes, brain remodeling and body composition changes, during which we do not want to interfere with the nutrition. Talking about nutrition, a nutritional evaluation should be performed by a qualified dietitian, where we look into the food preferences, we look into weight gain history, attempts at weight loss. It gives us some information about the motivation level of the patient. We look into the history of smoking and alcohol. Ideally, all patients should quit smoking before bariatric surgery, but if they do not quit, then there are implications, as smoking can increase GERD in a restrictive procedure and it can lead to other complications like marginal ulcers in a bypass procedure. Alcohol history is also important, as those who are alcohol dependent may become even more dependent after bariatric surgery, and it can be a reason of weight regain in the future. We also look at the physical activity levels, whether they are able to do it and they are willing to do it or not after bariatric surgery. Eating disorders are again very common in this patient population, so these should be ruled out, and if they are there, proper behavioral modification should be started and continued post-surgery also. Tests for nutritional deficiencies should be done routinely. These are the tests which have been recommended by the ASMBS Integrated Health Nutritional Guidelines. So for routine and iron profile, vitamin B12, entire calcium profile, fat-soluble vitamins, serum folate and thiamine levels should be done routinely. Whereas for gastric bypass, they recommend that zinc and copper should also be done preoperatively. If we find any major deficiencies in these patients, then they should be corrected before surgery. Psychological evaluation, this is to assess the motivation level of the patient and also to look at the mental health. Any active, untreated psychiatric illness is considered a contraindication, but controlled disease is not a contraindication for bariatric surgery. History of alcohol and drug abuse, again here is also important, and patient social support system should be looked at, especially at extremes of age. Some clinical causes of obesity, although not very common, should be ruled out. The common ones among these being hypothyroidism, Cushing's, and PCOS, and entire insulin resistance spectrum. And if they are there, they should be further evaluated. In adolescents, we should look into syndromic causes of obesity if we suspect based on facial, physical, cognitive features, and they can be further evaluated by genetic testing. These have implications in the type of procedure that we are going to choose for the patient. Next evaluation is evaluation of comorbidities. These are the common comorbidities that needs to be evaluated. Let's look at them one by one, starting from diabetes. So we start with history, because right from history it has some relationship to the outcome the patient is going to have with respect to diabetes remission. So if you look here, age, duration, medication requirement, if these are on the higher side, these patients tend to have poorer outcome. As compared to those who have higher BMI, they have better outcome. We also look into the compliance history and current glycemic control. These are the various investigations from diabetes point of view. The important ones to discuss here are the C-peptides or the insulin level. We do these to assess the beta cell mass and function. If these levels are good, then it's a good predictor of diabetes remission or improvement after bariatric. In very young adults, if we see very high insulin requirement, we should rule out latent autoimmune diabetes of adults by doing antibodies. This is important because this type of diabetes does not improve after bariatric surgery. We also look into secondary micro and macrovascular complications. Various predictive scoring systems have been developed to predict the outcome of bariatric surgery with respect to diabetes, like ABCD score, DIREM score, DSS and IMS score. Let's look at one of them. ABCD score, where ABCD stands for age, BMI, C-peptide and duration. So this is a comprehensive score which varies from 0 to 10, and it has been seen that scores greater than 7 have more than 90% chances of remission of diabetes. Obstructive sleep apnea, another important comorbidity found in 40% of obese patients. The history is given by bedtime partners of snoring, snorting, gasping, and episodes of apnea. Patient may also complain of daytime sleepiness and morning headaches. We can stratify the risk of obstructive sleep apnea in these patients based on this questionnaire called the Stop Bank questionnaire. Based on this, those who have intermediate and high risk can be evaluated further by a sleep study, which is considered a gold standard. It also tells us about the severity of obstructive sleep apnea and stratifies it into mild, moderate, and severe. And based on this, we can optimize the patient using CPAP or BiPAP therapy. For mild to moderate disease, we can do it for 2 to 4 weeks, and for severe disease for 4 to 8 weeks, and then reassess the patient for surgery. Cardiac evaluation is as per routine for most surgical patients. Another important comorbidity in bariatric patients is presence of NAFLD, which is seen in 65 to 95% of the patients. So here we look into the blood parameters. They generally have a higher SGOT levels and low albumin levels and lower platelet count. If we suspect any chances of cirrhosis, we should look at fibroscan, even do a liver biopsy. Now, this has implication in procedure selection, as most centers tend to perform in cirrhotic patients a restrictive procedure. Whereas we also discuss with the patient the chances of improvement, especially of NAFLD and NASH after bariatric surgery. Another important comorbidity is presence of GERD in bariatric population. It is 6 times more common. We look into the symptomatology of it. It has bearing on procedure selection. Most centers do not tend to perform a sleeve in these patients. For investigation and upper GI endoscopy, which is considered mandatory for all bariatric patients, we look into the abnormalities like esophagitis, Barrett's, hiatus, H. pylori. 24-hour pH study should be performed only in those patients where the symptoms are doubtful and we are considering doing a sleeve. So in order to rule out GERD. Coming to risk evaluation, DVT is the most common cause of 30-day mortality in bariatric patients. So this risk needs to be stratified. We must remember that most events happen after discharge. So in order to stratify this risk, we can use certain risk assessment models such as Caprini risk assessment model. Most bariatric patients fall into the category of moderate to high risk for DVT. DVT prophylaxis is recommended for all bariatric patients and it should start 1 day prior to surgery. And we can continue it for 5 to 7 days after surgery for mild to moderate risk patients and for up to 2 weeks for high risk patients. For very high risk patients, it may even be continued beyond 1 month. Mechanical devices such as sequential compression device and early ambulation are also important. Finally, a word about liquid diet, usually recommended for 2 weeks before surgery. The advantage of this is that it jumpstarts the weight loss of the patient and it allows reduction in the liver volume, which helps us during surgery in better handling of the liver. So in conclusion, all bariatric patients need to undergo a comprehensive pre-op evaluation as it is the basis for patient selection, procedure selection, risk mitigation, and optimal outcome. Thank you.
Thank you, Siddharth. Very good.
morning,
Nice
sir.
presentation, and you covered almost everything. If you can have questions.
So only one question. Every time I saw Bhattacharaya at all, is that you?
Yeah, that is me, sir.
Fantastic. You've got a lot of applications that I was not aware of. So congratulations. It's a very comprehensive talk. It's something that we could use in our workshops and Aussie also for guidance.
Thank you so much, sir.
Thank you, Siddharth.
Thank you, sir.
One question can I ask? This is quite comprehensive. Practically, do you feel that you follow all this?
Practically, sir, let's see, most of the things we follow, nutritional evaluation we'll follow. Psychological evaluation is selective. When we see certain patients who have alcohol dependence or we are suspecting major eating disorders, that's where we will do a psychological evaluation.
And do you do endoscopy routinely for every patient preoperatively?
Yes, we do routinely.
Though you mentioned it is mandatory, it is not mandatory.
It is not mandatory. European guidelines make it mandatory, but Americans follow it selectively.
Even I don't do. I do
yes.
only to those who are symptomatic.
Yes.
And third thing, which we talk about H. pylori, I have not seen a single patient who is not positive in last few endoscopies who was there for those persons who are symptomatic. So almost everybody is positive. So
Evidence of H. pylori is, sir, there is no recommendation to treat it preoperatively, and no difference has been found as those who were treated and not treated after bariatric surgery with respect to complications, even in the recent meta-analysis. So H. pylori is there. Most surgeons prefer to treat it. It depends, sir.
Great, thank you.
How much smoking you think creates a problem?
Smoking, so what we follow is that if we are doing bariatric for smoking, a patient who is not going to, who is going to continue to smoke, especially if we are doing a bypass, then we explain to them that we are going to put them on lifelong PPIs. Because otherwise the chances of marginal ulcers are anyway higher in the smoking group. And on the other hand, if we are doing a sleeve, then their GERD tends to get higher. So smoking, ideally, the patient should be able to quit.
Not only GRD, see, I think people who are smokers and after doing the sleeve or bypass, I think they lose more muscle mass also because, see, they reduce their appetite and smoking will further kill their appetite and they tend to eat less.
Right.
And so they lose more weight and more muscle mass also.
Right.
Do they have a higher risk of leak?
Higher risk of poorer healing is known, sir, but absolutely clear evidence is not there that they have higher risk of leak.
Has a higher risk of marginal ulcers.
Yes.
After bypass.
Thank you so much, sir.